Hello, everyone. Thank you for joining us today, and welcome to today's webinar. My name is Karen Somji, and I'm the National Priority Advisor at the Canadian Centre on Substance Use and Addiction, and I'm happy to be hosting the webinar for today. So to keep on time, we're going to just get started. And before we dive into today's content, we just have a few housekeeping items to review with you. So for those of you just connecting in, a quick reminder for audio to please click on the Quick Start tab, and under audio select either I will call in and call the number provided by phone or join in by computer using the ID provided. For any connectivity issues, please send a message to the CCSA host and presenter, and we will try to help out as best as we can. Just another reminder that all lines have been muted. We ask everyone to leave their lines muted to avoid any background noise. So to do this, you can hover over your name and then mute yourself, or do so by using the small mute icon to the right of your name. We also ask that you do not turn on video during the call to avoid any distraction. If you find your video is on, the no video function icon can also be found next to your name. At the end of the presentation, there will be an opportunity for you to ask questions. During the presentation, we just ask that all questions be directed to the questions user in the chat box, and we will be happy to collect questions throughout the presentation and then ask them for you during the allocated time. To find the chat box, and just as a reminder, please scroll to the bottom right of your screen. Alternatively, you can click on the top right-hand icon as well that says and illustrates the idea of chat. As we mentioned before the webinar began in the chat box, today's webinar will be recorded. And lastly, we will be sending out a brief survey after the webinar, which you will be able to complete online. So just as a quick backgrounder, as some of you may know, in November of 2016, CCSA joined over 40 organizations in signing a joint statement of action to address the opioid crisis. The Joint Statement of Action lays out a number of organizations' commitments to reduce the harms related to the use of opioids, and as part of our role in facilitating progress and collaboration among individuals responding to the opioid crisis, CCSA is hosting webinars to highlight the work taking place across Canada. So today's webinar will feature some of the valuable work of HealthCareCAN, and with that, I'd like to introduce Dr. Victoria Lee. Dr. Victoria Lee currently serves as Chief Medical Health Officer and Vice President of Population Health in the Fraser Health Region of British Columbia. As the Chief Medical Health Officer, her primary mandate is to prevent disease, protect health, and promote wellness in populations and communities in the Fraser region. This includes providing leadership and oversight in the area of mental health and substance. Dr. Lee also co-chaired HealthCareCAN's Invitational Roundtable with Dr. Philpott and will now be the lead facilitator for today's webinar. With that, I'll actually pass it over to Dr. Lee. Dr. Lee, thank you for joining us.
Thank you so much for having me, and I'd like to take the opportunity to first acknowledge Canadian Centre on Substance Use and Addictions for hosting and HealthCareCAN for coordinating this session. I'd also like to take the opportunity to provide a quick bio of Dr. Jeff Turnbull, who will be presenting later on the session, who is an internal medicine specialist, past president of the Canadian Medical Association and former vice dean of medicine at the University of Ottawa. Over his medical career, Dr. Turnbull became increasingly interested in providing better clinical care to Ottawa's homeless population, and we'll hear a little bit more about that and how the opioid crisis has impacted that population. He has helped to start Ottawa's Inner City Health Project and has been its medical director since its inception. And the Inner City Health Project from Ottawa has won numerous awards and also received international acclaim for its efforts. And Dr. Turnbull has also received many awards for his humanitarian and medical achievements. And we have not enough time to go through all of those today, but he'll certainly be on later on to tell us a little bit more about the opioids and the work in Ottawa. So without further ado, I'm just looking at our current activities here in terms of what we need to go through. I'm wanting to make sure that I'm going through the agenda with you, and seeing that I'm not able to change the slides yet. Okay, here we go. So in terms of today's session, we'll be going through the review of what's happened with the Ministerial Opioids Roundtable, and briefly going through the situation in BC where the opioid epidemic was declared a couple of years ago, and hearing from Dr. Turnbull, as I mentioned, in terms of view from the ground. So the first area that I wanted to note was that it was almost a year ago on June 12th that HealthCareCAN had hosted a ministerial roundtable with selected stakeholders, and at the time Minister of Health, Honorable Jane Philpott, regarding actions that we are seeing on the ground as well as leading practices across harm reduction, prevention, surveillance to treatment, and also share some of the challenges that were unique to hospitals and health regions and sectors. And there were commitments made and actions that HealthCareCAN members and partners made that we could take on to help mitigate the crisis that we're seeing. So I'll take a few minutes in the next few slides to go through some of those with you in terms of leading practices. And there was a review looking at what the current activities look like across various jurisdictions. And some of the areas in harm reduction that are worthwhile to draw your attention to include BC's First Nations Health Authority, who worked really hard to look at how harm reduction can draw upon the traditional knowledge of First Nations in BC. What we found in BC was that there's a lot of stigma attached to harm reduction or misperceptions about harm reduction promoting substance use. So those perceptions were also reflected in First Nations communities, and First Nations Health Authority has done a wonderful job of drawing on traditional cultural knowledge to debunk some of those myths. There's some really great work across the Yukon Hospital Corporation to, again, reduce stigma about using substances, and the campaign is referred to Don't Use Alone. We saw similar efforts in other jurisdictions as well. In BC, for instance, we find that 90% of overdoses are indoors, and majority of people also use alone, and that risks death as well. So one of the other areas that we thought were quite innovative was in interior health, where there was not only supervised consumption services that are traditionally open from 9 to 5, kind of bricks and mortar type of endeavor, but looking at mobile overdose prevention sites that provide similar services to supervised consumption services. So the next area that we looked at was across surveillance assessment to prevention. This is a big area, of course, because from surveillance perspective, we want to gather data that's across various sectors, and Alberta did that in looking at health data from EMS, emergency department, to HealthLink, to hospital data that puts it all together on one that can lead to more proactive action. And on the prevention side, there was a lot of work across jurisdictions looking at safe prescribing and more appropriate prescribing through a mandatory prescribing course, for example, at Eastern Health and at Hamilton Health Sciences. They were looking at opioid stewardship, and that was just approved through their medical advisory group at that point. We also saw some efforts starting in pain management, because we found that there was a strong linkage between people that are using opioids and have started to use street-based opioids that started their journey with prescribed medication. So University Health Network actually did quite a bit of work to reduce escalation of opioid dependency, especially in lower back pain, which we thought was also quite promising, and would be interested in hearing whether that kind of practice has expanded. In the treatment area, I think we find that opioids, as in other chronic conditions, there's a lot of relapse, and literature states around 80 to 90%. While we found during the roundtable that Sioux Lookout First Nations Health Authority actually had retention rates of about 72% after 18 months in a remote primary care setting, and they did a fabulous job of integrating the substance use treatment and bringing in the medical component as well as sociocultural components, as well as ensuring there's wraparound primary care for those patients. Other areas that are worthwhile to mention are specifically focusing on programs that are tailored to younger and adolescent populations, such as SIG kids, and then also in the area of training, expanding physician and nurse practitioner practice in this area. And in BC, for instance, now nurse practitioners are now able to not only monitor but prescribe Suboxone as well. In Fraser Health, we started this journey very early with identifying people that are at risk for opioids and following them through in community, and then actually starting and initiating treatment in our emergency departments. And I'll talk a little bit more about that shortly, because we will be delving a little bit into what's going on since the public health emergency was declared in BC. So the next area that I wanted to talk about was in challenges that we have experienced through the emergency. And the challenges that we had talked about at that time was around stigma and limited focus on prevention and lack of coordinated treatment services. So I'll go a little bit into details while you guys have the polling option to vote. I will leave it open for the next minute as we talk about it, and I'd like to share the results with you. I just learned how to do this on this WebEx format this morning, so bear with me if I struggle through it a little bit. So in terms of stigma, unlike other conditions or unlike other chronic conditions, we find that substance use overall, mental health to a certain extent as well, but with substance use, and especially with opioid, where it's an illegal, and I would say there's value judgment as an illicit substance, there's a lot of stigma about using substances, and that's why we see people using at home and alone and increasing their risks. At the end of the day, we're seeing that people would rather risk their lives than reveal that they're using substances. So that is an area that we're struggling a lot with, and even in our communities, those values are not only reflected in our community in terms of policymakers, we find that those values are also reflected in our healthcare providers. So that stigma is a huge area that I think everybody is aware of, but it's a challenging area to work on. The other area that we talked quite a bit about during the roundtable, and it's noted in the report, is around prevention. A lot of the times we know those that are at risk, whether they're coming through our health system through emergency department or even more upstream. I think if we ask teachers in high school or younger even, we would know where the biggest risks are. We recently found out through the coroner's report that there's a significant risk of people that are moving from correctional facilities into the community. So we know that there's a lot of risks and where we can do more to prevent, but because the emergency is hitting us so hard and so quickly, and it's difficult to move various levers in action, we find that there's limited focus on prevention, even though we know that we need to do more in that area. And in terms of lack of coordinated treatment services, at least in my jurisdiction in BC, a lot of substance use services are privatized and contracted, and we have very little publicly owned operated services. So with that, I would say it's a bit of a wild, wild west when it comes to treatment services, lack of evidence that's actually integrated into treatment settings, moral value judgments that are made in terms of what's actually included in treatment. And then thirdly, we also find that there's very difficult to actually access information from family and patient perspective. So we have about, looks like a little bit over 50% that have voted so far. And I'll close the poll and see if I can share the results with you. The tool is telling me that we have to wait 10 seconds to get the results to you. Let's see if I can reveal that. Okay. Share with attendance. Here we go. So as you can see, most people actually think that we're about the same in terms of the key challenges that we're dealing with. 50% of people, that's actually quite good, believe that things have improved slightly, or a little bit at least, and 3% believe that things have, those three areas have worsened. I think if I didn't get a chance to vote, if I were to vote, I would have put myself in the slightly improved component where we are at. Certainly we've seen some movement in stigma and also coordination of treatment services. I think we are still struggling with all those three areas that we have mentioned. Now, shifting a little bit to focus on BC, I'm not going to take too much time because I want to make sure that we have a little bit of time at the end for you to ask us questions and for us to have a discussion, and also, of course, for Dr. Turnbull to talk about what's happening in Ottawa. So I wanted to just highlight that there is a report that I've released in Fraser Health called the Hidden Epidemic, the Opioid Overdose Emergency in Fraser Health and Experiences that we have had here. And the reason that I talk about it as a hidden epidemic, I will share with you in the following slides. In BC, as I mentioned, we declared a public health emergency 2 years ago, and just for your information, public health emergency this was the very, very first time that there's been a provincial declaration of public health emergency. So what has happened is, as you can see demonstrated in the maps, and it's not as stark as what you would have seen if we put a map there that was from 2004, say, to 2005. But as you can see, that the situation has dramatically worsened still from 2017 to 2018, and the public emergency was declared in 2016. In total, BC total deaths have gone from 368 in 2014 to 1448 in 2017, and up to 391 deaths in BC as of March 2018. And 1/3 of all of those deaths in the province are in the region that I work in, which is Fraser Health. We have 12 acute hospitals and 22 municipalities that are in our region, and over 30 First Nations communities as well. So very complex in terms of the work that's going on here. Also devastating because, you know, just within my region alone, we've had nearly 500 deaths in 2017 and 121 so far up to March in 2018. And I find, sorry, the slides didn't quite come out the way it should have here. I think it was supposed to come in as an animation, but what's behind what you see in front of you is that we're seeing a pyramid impact. So the I talked about was really at the top of the pyramid, or top of the iceberg, as you would call we call it, and the end bottom parts are really people that use illicit substances, and then people that have opioid use disorder, people that are overdosing at home or in the community that we're not aware of, and people that come into our emergency departments and are treated, and then another layer on top of that are people that are hospitalized. So the layers below are quite deep and broad from what we've found, and we're talking about numbers that are well over 100,000 in terms of people that use opioids illicitly. So who are those that are dying from overdose? It's impacting mostly men, 85%, and 19 to 59 years old. In terms of 90% are in that category, and 30 to 39 is the biggest area of peak. And as I mentioned, not only are the overdoses, although image of people that are dying are often more on the downtown east side of street and trench, and they are very much a vulnerable population. There is an overrepresentation of First Nations, Aboriginal people, but we find that by and large, 70% of people that are dying are actually dying in private residences. And most people are dying in the communities that they live in. So this slide talks about some of the opportunities that we have seen, because the reason that we're not seeing these folks, even in our expanded services and health services, because they do not want to reveal that they're using substances. And the arrow there goes from where we have more of locus of control from health authority perspective to where we don't, but where we need to work more in actually going to where people are at and ensuring that they're aware of all the services, and we remove barriers as much as possible. I am not going to go into this in detail at all, but I wanted to highlight that and share this information with you just so that you have it. We've done a deep analysis of what we have over 6,000 emergency and department visits, and the deaths that we have seen, and where we actually can group people to which categories of people that we have seen. And we found that 90% of people that have died in the 12 months prior to their death come into our emerge at least once. Now, they don't necessarily come in because of mental health and substance use issues. That's about 40%. A lot of them come in for non-specific issues as well as pain, stressors, etc. So that's an area that we wanted to really further explore. And the next slide talks about where we see the biggest opportunities in the health system. I think as a patient and family right now, you have to dedicate your whole life to being a patient, because we make it pretty hard for you to actually have treatment, whether it's clinic-based, whether it's outreach-based. Not as many options are accessible. Sometimes you have to go in to be observed. Sometimes you have to not be on any treatment in terms of opioid agonist treatment to go into facility-based treatment. So all of those things we're looking at to remove barriers. We're trying to integrate into our primary care model as much as possible. We're also trying to have a one-stop gap in terms of instead of having people navigate this very complex landscape, if we can do anything to remove some of those barriers and navigate that for people. Some people talked about having hotel.com type of a site so that people can actually see what kind of treatment options are available and ensure that they're at least meeting the minimum standard of treatment in evidence-based practices, and that they would be able to see how patients have found those services in the past. Right now, what we're really focusing on is removing barriers that we have in treatment and harm reduction and prevention, so that it's integrated and coordinated, and as much as possible virtual and anonymous. So there's a lot of apps under development in those areas, as well as virtual care and coordinated care supports that we're looking at. And I tell some of the folks that it's really difficult to get men in that age group to engage in healthcare in the first place. When we look at that specific demographic, we really have to think differently about how we are providing services and how we're trying to reach out to them in the first place. In terms of provincial perspective, there was a coroner's death that was done, and we are looking at whether we can do more to putting more regulatory approach to recovery homes, because there's hundreds out there that do not have any kind of regulatory control at this point. And we're also finding that our treatment guidelines that has been disseminated now over a year and initiating and maintaining people on opioid agonist treatment and Suboxone has been very successful. No one has died while on Suboxone. And there's a lot of innovative ways that we're looking at other providers, for instance, pharmacists potentially get involved in treatment. And lastly, we are putting a lot more emphasis on community action. There's been an infusion of funding from the provincial group, so we have completely changed our structure. There's Overdose Emergency Response Center at the provincial level that's led by a group of folks. There's now community action teams in priority communities across BC that are mandated to bring people together from schools, from health, from community agencies, from police, and from municipalities to actually have collaborative action across the areas that are noted in the slide. And we're seeing some of the results of that. This is just a photo from one of our communities where youth had put together a photo journey of what people see on the ground with the opioid crisis and what we hear from them. So with that, I will turn it over to Dr. Turnbull.
Here we go. So thank you very, very much for inviting us, and thank you, Victoria, for your kind introductory comments, but all your other work that you've been doing so much on the opioid crisis. So thank you. What I wanted to do is give the perspective. Victoria's spoken very much at a national and provincial level, but I would like to give you the perspective of an opioid crisis that's the view from the community. And I guess the takeaway that I would like to leave you all with is that whereas this has obvious provincial and national implications, it's been felt most acutely, and the action is occurring most prominently right at a community level. And over the next little while, I hope that I would be able to tell you about that. That's if I can get the slides to go forward. There we go. Well, there we go. All right, now we know how to do it. So homelessness in Ottawa, just as a background, I'm going to talk about the opioid crisis from the perspective of our most vulnerable and marginalized community, and that is the homeless. Just to give you a background, we have about 7,000 individuals who are homeless every year. That's about 1,000 a night in our beds. It's changed very significantly from the domain of the adult male alcoholic to now women, families, youth, refugees, the very young, the very old. We now have a very broad mix of individuals. And in fact, the fastest growing component, even though they don't represent the highest in absolute numbers, fastest growing number would have to be adolescents. So that's that context. However, I think the important thing you have to know about homeless are these are our most vulnerable, as I mentioned, but the very high prevalence of mental health and addictions. And so naturally, you would expect that the opioid crisis would play itself out most prominently here. So as a response to homelessness in general, we've been working over the last 20 years to provide integrated, comprehensive services to our homeless community, and we've grown dramatically. We have harm reduction programs in managed alcohol. I'm going to tell you about TED in a second. We have hospice services, one of the largest hospices in Ontario. We have special care units for both men and women. We have primary care and nursing units. We have 4 different hotels, and we have programs and services right across the city. And as you can see, every one day we would have about 260 to 280 active patients within our roster that we provide integrated services for. And we provide, in addition to that, services for people who are not in our program, but they might be under bridges, in fields, wherever they may be. We'll go out and find them and bring them in. I wanted to tell you a little bit, because it relates to the opioid crisis, about TED, Targeted Engagement and Diversion. This is a program we've been working with our paramedics and our police. And those ambulances are not picking people up to take to the hospital. They're actually bringing people to us by ambulance. They've been picked up throughout the city. We divert them from the emergency department and the cells. And these are people in crisis, often with an opioid crisis. And so they're being actually brought to us and not to the hospital. Another reason why I would argue that we deal with this problem almost exclusively now in the community with very little contact with hospitals. As we go down, I just did want to talk about how this has affected us. So I'm going to tell you about what life was like first in Ottawa in the halcyon days of the spring of this last year, right up until the present. So I never thought I would see anything worse than crack cocaine, and I said cocaine has destroyed our community. That was a long time ago. Back in, I think, January, February, March of this year, we knew, looking at the BC experience, that the opioid crisis was starting. We, at that point in time, were having about perhaps 2 overdoses, 3 overdoses per week. We had 1 or 2 scattered deaths. And we started preparing the community, which I'll describe in a minute. Then in August, we know, well, in July, we had an increase in the overdose rate. We noticed it going up to around 5 overdoses per month. Then in August, we had 35 overdoses. In September, we had 75 overdoses, and now we have about 4 overdoses a day. We have trained 500 individuals in naloxone. We have, last month, we gave out over 2,000 doses of naloxone. And so we've had deaths on a repeated, regular, weekly basis. We have been resuscitating individuals in the center of some of our biggest streets, King Edward and Murray, right in the middle of stopping traffic. We have resuscitated people through chain-link fences, and it has so adversely affected the community that those individuals who we used to know as being stable are no longer stable. They've brought a whole new element of violence to the community and disruption. So I'm going to explain and try and describe how we've responded and then the things that I've learned from this. So if we can go to the next slide, is we began by warning the public what was happening. And we worked very closely with the injection drug using community, and we started to make them aware of things as well. Naloxone now is pervasive, it's everywhere. We've had to start to change our protocols so that 1 dose of naloxone if they're not responsive, we go up to 4 doses of naloxone. We started a safe injection facility, and my last quarter of this showed that we had 21,000 encounters in the last quarter, so busy. If you think about it, and I was impressed with when we had the safe injection facility, that really that in its own right is just to keep people alive. And in fact, it didn't make a whole bunch of sense to us that we would allow somebody to be involved in straight work, earning between $150 to $200 illegally through street prostitution, theft, or dealing, only so that they could buy drugs that were poisonous, laced with different toxins, and then inject them in our safe injection facility, and then we would resuscitate them and think that that was a success. So as a result, we started both an oral opioid substitution program, but more laterally, we've been giving injectable opioids. We have a group of 26 individuals who we've been giving injectable Dilaudid and stabilizing them to a point where they're no longer injecting outside of the program. They're now stabilized in a unique housing environment just for them, and I'll talk about some of the circumstances, but under those circumstances, they've found that those were our most high-risk individuals, overdosing probably about 3 times per week on average, and if we were able to do this, we could then stop the high risk of death and move them to a point where we can start to treat their profound mental health challenges that underlie all of this. And I'll talk about that finally. So that was our response. But again, to say that this has been totally inadequate, and I never anticipated just how dramatic the change was going to take place, and that had I known that back in the halcyon spring of this last year, I'm not sure how I would have reacted, but it's sure not the same, and life has not been the same. So let me just tell you about finish by telling you about some of the things that I've learned. This is a problem that is most prominently felt at the community. The community, our business community, our injection drug users community, the service provider community have all been overwhelmed with the magnitude of this problem. Crime has gone up, other drugs has gone up, crack cocaine has gone up. We find that there is nothing that is the same. So crack cocaine has, as of today, we just tested our last amount of crack cocaine that people are using. It has methadone, it has fentanyl in it, and it had oxys in it. So nobody knows what people are using, and the thought that one, exclusively is a heroin addict, who knows what they're injecting now. So it's been a very dramatic change. I'd have to say this is not a problem of those living in extremes of poverty. Victoria's highlighted that. My circumstance is, but I'm now seeing many people coming from suburbs. Many of them are high school students to inject in the safe injection site. And I've come to know, I thought I knew everybody who was homeless in Ottawa, but now a very significant group of individuals have come out who were quietly opioid addicts, who have now, with this whole overdose circumstance has brought them out into the open. And then I'd say there are some common generalities. Many of these individuals were prescription opioid users. Substance use is very common, as I mentioned. And then underneath this is this profound challenge of addiction, mental health, trauma, and culture. And just to give you an example of that, once we stabilize people with injectable opioids, what happens almost always is that individuals then start to talk about the huge amount of mental trauma that they've experienced throughout their life, and that they're actually using opioids not to get high, as they tell me now. They're using it just to get numb. This is the only time that they feel normal, not high, just normal, and they don't have to experience repeatedly that history of trauma that they've gone through throughout their whole life. And so the other group we see is they're using drugs to treat an undiagnosed mental illness, and the challenge now is, okay, you can stabilize people, you can actually keep them safe for a period of time, but it's going to take years to address their profound mental health challenges that go along with their addiction, and a lot of that is associated with culture, trauma, and the lives that they've been living for years on the street. Just a few more. We've been led dramatically by the people who were injection drug users. They told us how to work and behave, and we were willing to follow, and that served us very, very well. Another group, peer workers who have had lived experiences, are fantastic. I can't speak highly enough about them. They put me in my place when I need that, and at the same time have that street cred that people listen to them. I don't think we're going to get too far in this crisis unless we start to address some of the social determinants, and we have to be prepared to think about how we're going to address issues of poverty, poor education, lack of employment, lack of housing, as part of a solution of a complex problem like this. And then I firmly believe that we're not going to find an end to this opioid crisis easily. I don't see it letting up. I see the challenges as being very profound, and I think that this is going to be something that forces us to rethink some of our policies as it relates to drugs and addiction. Finally, I think it's important that we all remember that we're going to have to take risks. We're going to have to be prepared to fail and start again, but inaction is not an alternative. I don't think we can sit and watch people die, and whereas we may not have the right solutions, we have to try. So I'll stop at that point in time, and I'll turn it back to you, Victoria.
For questions and comments as well to learn from you, and that's going to get facilitated through HealthCareCAN. So are there any questions from that we had accumulated over the presentation?
Victoria, I've been given one, if I could respond to it.
Sure.
How do you go about getting approval for the injectable opioid substitution? That's a really good question. Nowadays, the federal government is easing some of the restriction on diacetylmorphine, which is pharmaceutical-grade heroin. However, we know from the experience from out west is that when you compare head-to-head diacetylmorphine with pharmaceutical-grade heroin with dilaudid, there is very, very little difference. And so we use injectable dilaudid, and that is something I can prescribe. And we do it in a supervised environment, and we use dose that I'm not ever being used to, but on the other hand, again, led by the addiction community, we haven't put anybody at risk.
And to expand on that, Jeff, we have been expanding our injection opioid agonist treatment in BC. It started in Crosstown in Vancouver, initially with 50 patients and now expanded to, I believe, 150 patients, and are looking at various models of embedded primary care model, of some that are going through more substance use specific areas as well. And then within my setting in Surrey, we'll be opening up soon with 50 people to start with. So there's an expectation with restriction provincially to expand our addiction opioid agonist treatment. And as Dr. Turnbull mentioned, that not only do we have evidence here, but evidence from across different jurisdictions in the world that this can work very well, I think, where we're challenged in numbers. So this is one component of what we find is part of our solution, but certainly the numbers that we're seeing in terms of scalability, we won't be able to manage our current crisis 50, 20 at a time. So that's been one of the biggest challenges for us. Now, I have another question here. What is done for the people who do not want to participate in the new program?
Maybe I could talk about that.
Sure.
So for those people who don't wish to participate in injectable opioid substitution, and I would be quick to point out that this is not for everyone. This is for the most refractory heroin addicts that we address who are at the highest risk. For those people who either wouldn't qualify or don't wish to be in this program because there is a lot of regulation to it in terms of you have to be available for your injection, we have to observe you before and after, part of that is that you participate in getting your mental health and your physical health improved, and that we move you into housing, et cetera. So some people are just not ready for that or don't want that. So we still make the safe injection facility available to them. We still make all other services available to them. And we make oral opioid substitution available to them. And with time, they may or may not wish to join us.
I think that's an incredibly important point that, sometimes from societal perspective, we hear that, well, all you need to do is get them in treatment, get them into beds, get them out, and that's what we need to do. I mean, in BC anyways, there's a lot of stories around we just need more detox and more beds, which we know, number one, we can only connect and be useful and supportive if people want to connect with us in the first place and that they want to go into treatment. And in terms of opioid use disorder, detox is actually not recommended in community-based opioid agonist treatment, whether it's oral or injection form is where we need to go. That challenge in terms of participation, I think we do need to pay attention to removing those barriers, especially people that are working at home or working or in education systems, et cetera. And those are some of the areas that I talked about earlier. I see that there's another comment around educating folks around low risk of arrest, as well as people being able to go back in overdose after naloxone wears off. And I think the comment was around being an outreach worker. There's a lot of clients that are trained on naloxone, and that's used before calling 911, but they're very scared about being arrested, so they don't go any further than that. Are you seeing that in Ottawa, Jeff?
Yes, absolutely. So there is, I think that, well, we have first of all, as we do a lot of the reversals with naloxone, we have an arrangement with the police that we wouldn't call them. And so basically the homeless community and the injection drug using community recognizes us as a safe zone in that regard. Our police also, to be honest with you, are now changing their attitudes, saying it's not in their best interest to arrest people because they're using. And so unless you're a dealer where they'll think more seriously about things, they're trying to keep away from the average user. Now, that's not always the way. The other thing is that a lot of my injection drug users don't wish to have Narcan at full doses. They work very hard, they'll tell me, to earn the money for that injection, and to have it reversed totally for them is something that they don't want. So we've been often using half doses or observation because we have a very well-staffed observation unit with oximetry, ECG readings, and rather than sending people to the up to the emergency department, we observe, and that's often been very successful. Hydration, oxygen, a little bit of naloxone wherever we need it, and then talking to them about the risks that they're putting themselves through.
Thank you for that. We have a number of questions, so I'll try to move through them quickly because we have about 9 minutes left. The first question is, what are your recommendations for busting stigma and generating increased support for decriminalization and shift toward public health models? So I can start, and Jeff, feel free to add. I find that one of the, from my physician public health training, one of the things that I look at is what are the root causes, and in this case, significant root causes around stigma and supply, and a lot of the areas that Jeff mentioned earlier around early childhood trauma. So when I look at the stigma and supply issue, where we have locus of control is around injectable OAT, collaboration between police, social services, housing, health, and other sectors. And then in terms of where we don't have as much control, but where we can advocate, is around decriminalization and legalization. We have done a lot of work in BC in trying to look at what that looks like and bring in experts from Portugal, looking at how that's been accomplished. Maybe not exactly the same as Portugal, but in the UK, what's been done in Australia and other settings, or where are there learnings we can take on? And we share that regularly with our policymakers. Some of the municipalities, like Vancouver, has been calling out publicly for decriminalization. So I think that's an area in terms of, I think Jeff, you were alluding to courageous and not being afraid to take risks. With the crisis that we have, I do think those steps are what we need to take on. Jeff, did you want to add anything to that response?
No, I think the more we speak out about this and the more we get people to recognize that this is an illness, this is not something of choice, and it's a consequence actually of many of the failed systems that we have within our society, whether that be in circumstances of the family, the child welfare system, how we've treated our Indigenous communities. All of those are failures of our community in general terms. So we own the solution. So the stigma, I think, should be moved from the individual to one of being a community response. I think when you have the police and the paramedics and other institutions standing up and saying, we support these types of things, and the more we hear about it, the more people on the line, the more webinars like this, is going to really change the stigma associated with it.
Thank you. And is there any learnings from BC in terms of what the province has led or is providing in terms of support for initiatives, especially in relation to injection OAT, that would be useful for Ontario to implement? I think there's been a few learnings. One, there was that international trial that was done, internationally published trial that was done in BC, and we found that hydromorphone is just as effective as diacetylmorphine. So we're moving towards with hydromorphone, which is less expensive. And secondly, there's been we've also looked at various models of where we can provide this in the most inexpensive way, because there's ways to do this with a lot of security, and because these drugs have a lot of high street value, having all the security involved, having different types of people involved, community pharmacy versus health authority pharmacy, exemptions, etc., that we have learned through our process and our expansion, and I would say we're still learning, but there are some lessons learned I think that would be helpful, and certainly having guidelines here, clinical guidelines that looks at injection OAT, what's the criteria, and having an ongoing mechanism to evaluate has been helpful.
And Victoria, as you probably know, there is now a national group meeting to determine what some of those national guidelines would be for injectable OAT. So I think those people on the line and others will see drafts coming out very soon, and it's led by groups from BC who have had the most experience in this regard.
Yeah, and I think I find this, and Justin probably see it on the ground too. Here, I find that even in just oral OAT, and even more so with injection OAT, even with oral OAT, there's still a lot of stigma and criteria for patients that they have to completely flip their lives around and engage in treatment. As an example, they have to demonstrate that they're not on any substances. They have to go to pharmacy to get the methadone, and they have to earn their carries, like things that still have a lot of moral and value aspects of treatment, and we don't do that for diabetes. I don't think that we should have those types of standards for people that are struggling the most and vulnerable, but aside from that, I think absolutely, I think some of the colleges really need to line up to where the treatment's going, et cetera, as well, because there's a lot of risk that the colleges, for instance, still identify in this area. So I have a lot of questions. Some of them we have touched on. Let me see if I can just pick a couple of them that we have not touched on. Which one is, do you have any thoughts about theories that move substance use away from a medical model towards a disorder of learning development? Is this true, and how might it change our approach? Jeff, do you want to comment?
Yeah, that's exactly how we have to move it. We have to move it from something where there's stigma and it's the fault of an individual. Then we've been thinking of this as an illness. And I think there are some elements that would be treated like an illness, like therapies, drug therapies. However, fundamentally underneath this is the broader determinants that led to this. And that's going to be the most challenging in terms of policy. But I can tell you that we will never get to the end of this crisis unless we start to address those broader things and get people to say this is, so many people, this is dyslexia, this is attention deficit disorder, this is abuse as a child, this is all sorts of those profound factors of poverty and homelessness and all the societal woes. So the more we move it in that direction, away from something that we blame individuals for, or we think that there's a magic cure to it.
Thank you for that. I think, Jeff, that's a great concluding remark, and I will use my little bit of time as a concluding comment to address one of the questions around best practices around prevention and talking to young people. I want to share my resource with you. We've done a lot of work to talk about how do we actually talk about this issue with our loved ones, whether they're youth or friends or family, and that's, I think, one of the most critical factors that we found for individuals that are engaged in care. They said that the biggest difference for them was when they felt like somebody cared for them. So I think there's some resources available for that, so we'd be happy to share that with you. And with that, I will turn it over to the folks from HealthCareCAN and also from the center to see if they have any final remarks.
Okay, thank you so much. And with that, we'll just be wrapping up. So thank you to HealthCareCAN, Dr. Lee and Dr. Turnbull, as well as everyone on the line for joining us today. Just a quick reminder that we will have a survey link that will be sent out following the webinar for an opportunity to provide feedback and comments. And what you'll see on the slides here is a contact for questions related to any of the content that you heard or saw today. So if you have any questions around any of the things that you've seen today, please contact Siri, and her contact is there on the slides. And then for any questions related to the joint statement of action, you can connect with myself, and my contact details are there. So thank you again to our presenters, to HealthCareCAN, and for everyone for joining us today. Thank you so much, and have a great day.